Topic is fibromyalgia. What should a pain physician know? Now, this is one of the diseases that actually is very common in the society. And sometimes what happens, patients comes with this disorder, and this disease can mimic various other disorders. That means if the patient is suffering from such disease, and if you are doing treatment, then unless and until you properly able to diagnose these cases, you might go or directed towards the wrong diagnosis and accidentally, ultimately, you will not be able to give the proper result. So let's start with the case. And the case of Shadhana, a 40 years female attending pain clinic with history of pain, suffering, which is actually from scalp to toe for last 4 years. Sometimes the pain is burning and cramping in nature. She gets tired easily and with all of his activities. Her sleeping is restless. She awakes tired and complains of recent loss of memory. All our investigation reports are within the normal limit. So those who are practicing any medicinal practice, whether it's a general practice, orthopedics, or any other practice, these patients are usually seen in most of the clinics. Now, what is fibromyalgia? Fibromyalgia is a complex and chronic condition associated with widespread muscular pain with the presence of tender points, and these tender points are specially located in the musculotendinous junction, and there are other associated symptoms like the fatigue, anxiety, depression, which may be associated. Some patients might have sleep disturbance. Sometimes the patient might have moral stiffness. Sometimes the patient might feel paresthesia. Sometimes the patient might be having a headache. So there are various generalized somatic symptoms along with pain. So this constitutes of fibromyalgia. Now, this is a disease that usually affects around 4% of the population, and it is much more common in females than males. And this disease is a long-term disease that is seldom curable, and it may be associated with the rheumatoid arthritis. Sometimes it may be associated with the systemic lupus erythematosus or hypothyroidism. What are the conditions that are associated with the fibromyalgia? Muscle pain, as it's a part of the definition, so it is present in all cases. Then fatigue, it is present almost in 96% of the patient. The patients usually say the patients are easily fatigable. Whenever she wants to work, she feels fatigue and which is excessive. Sometimes around 86% patients can complain of insomnia and sleep difficulties. Along with some patients will also say about the unrefreshed awakening in the morning. What is unrefreshed awakening? Our general phenomenon is that when we woke up in the morning, we feel fresh. But these patients never feel fresh in the morning. He always or she always feels sleepy in the morning. Some patient, he might be associated with a generalized arthralgia of the multiple joints. It may be associated with a headache. It may be associated with a restless legs at night. It may be associated with a paresthesia. Some patient complains of anesthesia while in the portion which is close to the bed, and there is pain as well. 46% patients might have cognitive impairment. And this is one of the very important symptoms of fibromyalgia. And usually these patients, how actually you can ask about this cognitive impairments. You ask the patient whether he or she forgets. Sometimes he has given something for the cooking and she forgets it. Similarly, same thing happens for the keys, locks, and everything. So in that way, there is recent loss of memory in these patients. There may be associated leg cramps. The patient might have poor concentration ability. There might be anxiety, and the 20% of the patient might have major depression. Now, now, this disease is known for long, but the first attempt, I should say successful attempt, to prove this disease was done by American College of Rheumatology, and they proposed the first diagnostic criteria for fibromyalgia, and that is the 1990 criteria for the fibromyalgia. They have said that it's a chronic, widespread musculoskeletal pain which lasts longer than 3 months in all four quadrants of the body. That means it's a generalized pain. And in addition, skeletal pain or axonal pain, they must be present. They must have 11 out of 18 trigger tender points, painful, with 4 kilogram of pressure. That means how it was measured? It was measured by putting the thumb before the tender point, and if the pain point is painful, while your nail bed is blenched, that is almost equivalent to 4 kilogram of pressure, and that is actually diagnostic of fibromyalgia. In our early days also, we have used this definition and we are able to diagnose the patient for fibromyalgia with this definition. But there are certain limitations with this definition. First of all, it is limited by requirement to perform a tender point examination. So, in epidemiological studies for the mass scale, it is not very applicable. Then some patients might have variations. That means in some days there is increased pain. In some days there is not increased pain, it's not there. So what will happen if we follow this criteria? In some days the patient will be classified as fibromyalgia, and some days the patient will not fall into the category of fibromyalgia, as it is not considering any other symptoms other than the pain. So variations are not considered, and it is not very reliable for that and difficult to use in clinical practice. Symptoms other than the pain, I have told you so many symptoms other than the pain, but they are not considered within this definition, and it delays in diagnosis as well as management. So what is the new fibromyalgia diagnostic criteria, which is published by again American College of Rheumatology in 2010? It is provided a more practical screening tool. It is no longer required by a tender point examination. It correctly classified 88.1% of the cases, defined using 1990 criteria, and it uses two indexes. That's the widespread pain index and the symptom severity scale to characterize all symptoms. Now, what are the fibromyalgia diagnostic simplified screening tools? It mainly has two parts. Part one, that is the patient self-administered. That is the widespread pain index and the symptom severity index. And part two, which is an evaluation by the physicians followed by further screening. So what is there in part one? In part one, body is divided into 19 areas altogether. And each area has given score 1. So what will happen? If the patient is having pain in that area, patient will write the widespread pain index score. And the total will be calculated, and the total number, that is 0 to 19, that will be the widespread pain index. And it will be, these are these areas. From the pair front and back, you can clearly see these areas. Coming to the next part, that is the symptom severity scale portion, which can be done by the patient. Three important parameters has been given maximum importance. One is the fatigue, then unrefreshed awakening and cognitive symptoms. Okay, so it is the part 2A part, that is the self-administered part of the symptom severity scale. So here it is divided into no problem, mild, moderate, and severe problem. And each character or attribute is given 3 scores, 0 to 3. 0 is the no problem, and the maximum with the severe problem, it is 3. Again, the scores will be given and the part 2A score will be calculated. So up to this part, there is no role for the physician. It is self-administered by the patient. The part 2B, the other somatic symptoms, there are altogether a big list, almost 35 somatic symptoms. They are listed, and it is the physician's judgment. He actually selects asking these symptoms that in which category the patient is coming. No symptoms, usually up to 3, 0 to 3, usually considered. Then few symptoms, when it is up to 10, then up to 20, it is given as a moderate deal of symptoms, and a great deal of symptoms if more than 20 symptoms are there. And now we have to consider the other few important points. That's the duration of symptoms and underlying disorder. So, duration of symptoms should be more than 3 months to be a chronic pain. That should be met in this criteria. And these conditions should not be explained by any other disorders. Say the patient might have rheumatoid arthritis, and some features can be explained by that. In that case, the primary diagnosis should not be a fibromyalgia. Primary diagnosis should be rheumatoid arthritis. It should be treated. And if it's with the normal CRP, the patient is having the pain, then we can consider a second diagnosis of fibromyalgia. So that is very important. That it's a diagnosis of exclusion. Now, when the widespread pain index is more than 7 and symptom severity score is more than 5, then we should consider as a fibromyalgia. The symptoms should present more than 3 months, and other disorders should not explain this condition. Similarly, when the symptom severity score is in between more than 9 and the widespread pain index is between 3 to 6, these patients are also considered as fibromyalgia. Now, there are few recommended investigations to rule out other conditions. They are the CBC, CRP, CPK, ESR, LFT, TFT, and that is the recommended tests to rule out the other associated conditions. So, this way, this criteria has made certain changes, and here the diagnosis becomes easier. All the symptoms are considered, and a lot part of this questionnaire is that can be administered by the patient. So it can take more patient of this criteria. But remember, even after 2010 criteria, there are certain limitations for the diagnosis with this criteria. For that, some newer modifications are also hypothesized. But even though the 1990 and 2020 criteria are not officially recognized criteria by the American College of Rheumatology. And these modifications post 2010, they are made to facilitate its use in the cognitive studies and reduce the requirement for a physician examination. And the symptom severity score and the widespread pain index is modified. Now, widespread pain index modification. Presence of a generalized pain is considered in 1990 criteria. But what happens with this new criteria of 2010, you have seen, if there is the symptom severity widespread pain index in between 3 to 6, even then it should be considered a fibromyalgia. So here there is a drawback that in those conditions, a localized pain can be diagnosed as fibromyalgia. See, suppose in a patient, if 3 areas like upper arm left, lower arm left, and a shoulder girdle left, they are painful. So in that case, simply a radiculopathy could transform into a fibromyalgia if other features are present because of the chronic sensitization. So this was a limitation that this generalized pain index is a little bit ignored. So here a modification is proposed where the body is divided into 5 regions. Okay, axial region, left upper, right upper, lower upper, and the right lower. Okay, and here the patient should choose one from each area so that this localized pain will not be accidentally diagnosed as fibromyalgia. And widespread pain index is increased slightly from 4 to 6 with symptom severity score more than 9. So that was a change which is proposed. Similarly, the second part of the symptom severity score, especially the physician administered part of the symptom severity score, is also being modified, and this modification is to help more in case of community studies where the whole diagnostic criteria can be self-administered by the patient. So here, instead of this checklist of 41 symptoms of the somatic symptoms, they have given three somatic symptoms maximum importance: headache, pain or cramp in the lower abdomen, and the depressive symptoms. So if they are present, they should be considered again in the 0 to 3 category in the fourth part. That means while we are checking these other symptoms and given this diagnostic criteria, instead of that, with newer criteria, they have proposed only these three most important generalized somatic symptoms. And they have given these additional points so that the whole chart or the whole process can be administered by the patient. And this is the 2016 modification of the criteria. So, by which the help of this criteria, we can diagnose the patient of the fibromyalgia, provided the pain is chronic, which is lasting for more than 3 months. And number two is very important. These pathologies cannot be explained by any other conditions. Now coming to the pathophysiology. Why this widespread pain syndrome occurs in these patients? Now another information I'm adding here. This type of pains where there is a generalized sensitivity symptoms without any inciting event. These pains are categorized into a new category by the IASP, and that is known as the nociplastic pain. Conditions like fibromyalgia, CRPS, non-specific back pain, they are put into this criteria. Okay, so these pains of fibromyalgia nowadays is known as the nociplastic pain. Now coming to the pathogenesis, the most important line is the first one, that the pathogenesis is not clear. There are a lot of hypotheses and certain clinical and biochemical findings that is well documented in fibromyalgia, but how they are actually linked with the disease and how it is automatically this cascade starts, that is not known to date. So what are the documented findings? It has been found that fibromyalgia may develop after a major trauma. Substance P in the cerebrospinal fluid for the patient with fibromyalgia may be 3 times higher in fibromyalgia. Low serotonin levels in platelets and CNS can be found. Low levels of the ATP in RBC and trigger points might be observed. Dysfunction of the hypothalamo-pituitary adrenal axis might be there. Low growth hormone level might be present. Large growth factor concentration is 4 times higher in the CSF. There may be a strong familial pattern and females are more affected. That is one of the evidences. And non-restorative display might cause this situation. So, but which one is the cause and which one is the effect among those is not clear. But whatever the cause may be, it has been found that the central sensitization is the key feature which is responsible for the persistence of pain. But these pathological abnormalities, which came first or the disease came first, that is not yet been known. Now coming to the most important part for us, that is the treatment. Because we have to treat these patients and successfully treat this patient, we have to depend on certain things. First of all, the pain-reducing medications like tramadol, paracetamol, NSAIDs, they can be prescribed for a short term. And the main drugs for this are the antidepressants, SSRIs, noradrenaline enhanced and serotonin reuptake inhibitors, and anticonvulsants. Among those drugs, 3 drugs are FDA approved. Among those, what most important is the pregabalin, which is first FDA approved drug for the management of fibromyalgia. The next is duloxetine, and third one is the noradrenaline enhanced serotonin reuptake inhibitor, that is the milnacipran. These 3 drugs are approved treatment for the fibromyalgia. Now, pregabalin, as I told, it is the first drug which to get the approval for the fibromyalgia. It reduces pain and improves daily function for some patients with fibromyalgia. It has 30% pain reduction, very small effect on the fatigue, and small effect on the sleep. It can cause mild to moderate dizziness. It can cause sleepiness. There is a chance of blood vision, weight gain, dry mouth, and the swelling of the hands and feet. In the class of our Pharmacological management, we have discussed long on the pregabalin, so we are not repeating the same here. Now, next drug, which is not FDA approved but widely used for the fibromyalgia, is the similar group medications, all are the centrally acting alpha 2 calcium channel blocker, alpha 2 calcium channel blocker. So, they are the significant effect on the pain reduction, small effect on the sleep, and large effect on the disability. Amitriptyline, it's a tricyclic antidepressant. It can cause 50% reduction in pain, moderate effect on the sleep, and a small effect on the fatigue. Next drug is the SNRIs. They are the non-tricyclic dual serotonin and norepinephrine reuptake inhibitors, among which duloxetine, which is 5 times more potent over the serotonin than norepinephrine. So it is in favor of the serotonin reuptake inhibitor, but it inhibits the reuptake of norepinephrine as well. And the milnacipran, which is twice more potent than norepinephrine than the serotonin. So these two drugs are used for the management of the fibromyalgia. Now coming to the user management recommendations. First of all, you have to take the history physical examination. You have to go for the diagnosis of the fibromyalgia. You have to remember that the patient education is very important for fibromyalgia. You have to go for the physical therapy. If the patient is not responding with this non-pharmacological management, then we have to tailor the individual treatment for these patients. If there is individualized this patient having more related to depression, anxiety, catastrophizing, and the overly passive and active coping, the psychological therapy is usually preferred, and more severe depression and anxiety, pharmacological treatment might be considered. Patient with a severe sleep disturbance, we can continue with the pharmacotherapy. For severe pain, we can use duloxetine, pregabalin, sometimes tramadol. But remember, while using SSRIs or SNRIs and tramadol, you should be careful of the serotonin syndrome. Again, we have explained this in our pharmacology class. Then, in severe sleep problems, we can use amitriptyline, cyclobenzamine, and we can use the pregabalin. If there is severe disability, patient is taking safe names, in those cases, you have to go for the multimodal rehabilitation programs. So that was in short about the fibromyalgia.